Hello, everyone. A warm welcome from the Australian National University here in Canberra. I hope you and your loved ones are keeping safe and healthy. My name is Dipti Talaulikar. I'm a hematologist and the program lead for the Global Peer Support Program at ANU. Joining me today are Jay Poria, who looks after international relations and partnerships here at the ANU in health and medicine, and Devashi, who is a volunteer medical student, and Pinky Dharmashaktu, another volunteer with the program. We also have with us our speaker for today, Dr. Ashu Gandhi, psychiatrist from Melbourne, and two esteemed panel members from India. I'd like to acknowledge the Gunawal and the Gambri people who are the traditional owners of the land where ANU is located, and I pay my respects to the elders past and present. Many of you are joining us from various parts of Australia and the globe, and I would also like to acknowledge the traditional owners of all those lands and pay respects to their elders past and present.
Thank you, Deepthi. It is indeed a pleasure to be here to present this talk, and obviously this is difficult times all over the world, and here we are going to talk about bereavement in the COVID-19 times. And I'll take you through a few slides, and I hope that, if there are questions that are coming, feel free to ask them, and we'll try to respond as best as we can, but knowing very well that time is limited, for any presentation, things like that. So, in today's talk, I am ably, and I'm privileged to have Professor Chaturvedi with me here, who is a consultant psychiatrist and the former Dean of Behavioral Sciences and a Senior Professor of Psychiatry at NIMHANS, Bangalore. In fact, I was thinking that, how to introduce Professor Chaturvedi, and I said, if I was to read through his achievements in life, I think it will take over the whole talk and we'll spend the whole hour talking about him. So rather than that, I must say that he's an esteemed professor, both internationally and nationally. And, he has got several thousand publications, and, he's edited various books. And, most important is that he is so well experienced, and, the pearls of wisdom are really going to be very important here. And along with Professor Chaturvedi, I've got Dr. Himani Kashyap with me, who is from the Department of Psychology in NIMHANS. And again, Himani, she's, a very bright brain in psychology. And, she will be able to kind of present the perspective, both from an Australian perspective, given that, till quite recently she was in Melbourne, and now she is in NIMHANS. So, welcome both Professor Chaturvedi and Himani, and hopefully, we'll kind of see how we go with the questions, and hopefully we'll be able to hear more from your experience in this talk. So without much ado, let's kind of go ahead with, what we have in mind is about grief. And I think we do understand that grief is a price we pay for love. And if there was no attachment, there would be no sense of loss. And I guess you all would agree with that. As we go ahead, we understand that death and bereavement are a natural part of life. And just to define, in terms of trying to understand what bereavement is and what grief is, we must put into perspective that bereavement and grief are used inconsistently. So these terms, the state of having lost someone to death or response to such a loss, so this is being used inconsistently. Bereavement is an objective condition of having lost someone significant, while grief is the emotional, cognitive, functional, and the behavioral responses to death, or it's a reaction to bereavement. Grief can be used more broadly to refer to other losses like youth, opportunities, etc. And mourning is the behavioral manifestations of grief, the actions and manner of expressing grief, which often reflect the mourning practices of one's culture. And mourning has got obviously different concomitants, and it's a very important way to manage grief and work through the issues of grief. Now, grief, as we have just heard, is a universal human experience, considered to be a natural and expected response to the loss of a loved one, and one of the most intensely painful of all human experiences. And it's variable, it's fluid, and it differs in intensity and length among cultural groups and people. Let's try to look at the anatomy of normal grief. What we need to put into perspective is that grief is not a state, but it's a process. It proceeds in fits and starts, with attention oscillating to and from the painful reality of death. There are barely noticeable alterations to profound anguish and dysfunction. It has the concomitants of shock, anguish, anger, guilt, regret, anxiety, fear, loneliness, unhappiness, depression, with intrusive images and even depersonalization and feeling of being overwhelmed. Thus, it manifests in many, many different ways. And why it is important to know that is to be able to have those red flags right in terms of what are the symptoms of grief. Now, we do understand that theoretically there are multiple stages of grief, and there are, Elizabeth Kubler-Ross talks about the 5 stages of grief, which is denial, anger, bargaining, depression, and acceptance. But does grief go through those stages in that way? I think it's important to put into perspective that grief and recovery do not follow an orderly state, sequence, or timetable, and they're not clear-cut. The bereaved individual may oscillate back and forth between any 2 phases, and we have already talked about the common reactions which ebb and flow over time. So while usually decreasing in intensity, various facets can surface unexpectedly, particularly around nodal events and salient dates. It's very important that we also pick up the signs of grief in children. Now, how can we tell if a child is grieving? There would be changes in the behavior, and the behavioral changes can be seen as difficulty in concentration, problems in sleeping, feeling abandoned, being clingy to the parent, regression developmentally, changes in usual behavior or play, and again, feelings of guilt that are being told. Now, we started by saying that death and bereavement are a natural part of life. But with COVID-19, we need to put into perspective, while death and bereavement are a natural part of life, global pandemics are not. And as we all know, the COVID-19 pandemic has brought havoc and disruption to the way we live and how we conduct our lives, that we have been starting to think about a new normal. There have been loss of lives and health, but also freedom, finances, livelihood, employment, and things very dear to us and our lives. These waves of infection have brought in increasing morbidity and mortality and have further led to a myriad of emotions that we have talked about. Now, when we talk about bereavement, there are a lot of factors that can influence bereavement. It's the nature of death, the context of death, consequences of death, and there are a lot of other factors like pre-existing factors of the bereaved person. Now, just before we get into trying to understand what are the factors which are specifically related to COVID-19 and the conundrum associated with that, can I get Professor Chaturvedi to comment about, does he think have been the distinguishing features of grief in the usual clinical practice, during these times?
Thank you, Ashu, and thanks for this opportunity to interact with all of you. I think it's been a topic which is being discussed amongst medical professionals and media day in and day out. Is about grief. And though, Ashu, you discussed about the usual stages of grief and about mourning, COVID has been, as you were trying to point out, has actually, what shall I say, it's turned the whole grieving process and mourning process upside down. And like, for example, mourning is hardly possible because for mourning, people have to go to the death ceremony. People have to go to the cremation. People have to go to the dead person's house. Now with social distancing, that has not been possible. So people are not able to mourn their loved ones. And what is going to be the impact of this? Only time will tell. When we see that, in a year, 2 years, 3 years, 4 years, 5 years down the line, when people would, think that if we didn't do the proper mourning rituals, the traditional rituals which they should have done, what would happen? So we know that, during the process of death, a lot of rituals need to be done. Now with the various guidelines, not more than 4 people or maximum 10 people are allowed to go for cremation. Whereas in our country, the people go in hundreds. So many have been left out. And then there are various religious rituals, all of which require people, and people have to be there. People cannot be there. And that is going to cause a biggest complication of grief reactions in times to come. There are two types of grief reactions which I think are very important during the COVID times. One is anticipatory grief. As soon as any person who has turned positive, obviously 90, 95%, 96% recover fully. But those who get into a hospital, those who get into an ICU, and then there is this lurking feeling that this person will not come back. And that starts the whole process of anticipatory grief. Whether we will be able to see this person again. So anticipatory grief has been, a very big phenomena. And another is anniversary reaction. Since it was already a year and a half of the COVID pandemic, people who had died about last year after February, March onwards, and this year. So any other news, triggers of PTSD-like symptoms, intrusive features of what they had gone through. This grieving during COVID is very different from grieving because of a person who had let's say, an ischemic heart disease, heart attack, diabetes, any other medical disease, or road traffic accident. Not that those are very easy to deal with, but this has caused a lot of problems. So I think this grieving is got a lot of uniqueness in it, which has not been there with other deaths.
Absolutely, sir. So I think, as we can see, and what has been brought about by Professor Chaturvedi is exactly that we are talking about, is that all the measures which are related to controlling the spread of COVID-19, like social distancing, quarantining, PPE, mask, lockdowns, these very restrictions which are designed to protect against COVID-19 have contributed to the distress and suffering. And that has made the grieving process extremely complex and complicated. And these two most important facets of life have been restricted: freedom and relationships. And that's where it becomes much more complex. And this is being obviously further complicated by the factors which are much more specifically related to COVID-19, is that the unexpected nature of death. Your loved one goes into the ICU and you think that, they're going for treatment, but, they are unable to survive. Inability to see your loved one in the final stages. Inability to follow the rituals, as has been pointed out. Restriction on many rituals. And also along with that, there is a kind of a guilt related to strong transmitter guilt. Have I transmitted the COVID-19 to my family member? And along with that, there are obviously so many losses going on at the same time: financial, job, shelter, needs, right? All of those are being affected. And in many cultures, there's a lot of shame and stigma and the fear of exclusion. So there has been a loss of a sense of normalcy all around. There's a sense of darkness all around, shattered assumptions about the worldview. And that continuing multitude of losses, it doesn't seem to stop. There are ongoing media news about the tragic deaths. There's a sense of disconnection and loneliness. There's the looming threat of ongoing waves and prolonged unemployment, and the loss of the pre-crisis ways of life and threatened loss of hopes and dreams for the future, which has really affected how we see life. So life has been derailed. So, and with this derailment of life, we understand that, as we talked about, our worldviews are shattered. And this is a collective experience. So whilst we have talked about death and dying or grieving as a phenomenon related to an individual, but here it's a collective experience of assumptions being shattered in our worldview. Our taken for granted beliefs and expectations about our lives and the connections to our world have been affected. And this starts making us feel that the world is unpredictable and unjust. And we see that COVID-19 deaths are solitary deaths without traditional rituals, often unexpectedly fast, without clear information, without any preparation, and with limited or interrupted communication bridges. Now, whilst we start talking about the impact on mental health and well-being, let me get Dr. Kashyap on board to understand from Himani as to what has been her experience in the last 1.5 years as a practicing psychologist in terms of what are the different presentations that she has seen in the regular practice.
Thanks, Dr. Ashu, and thanks again for having me here. So I think as you and Professor Chaturvedi have pointed out, there have been so many challenges with grief during COVID-19, and definitely there seems to be a variation in the way people present as well. For one thing, apart from what Professor Chaturvedi said about anticipatory grief, and what you said in the first slide, Dr. Ashu, about grief being a necessary component, being part of love. I think what we have seen also during COVID is that it is there is grief even slightly at a distance, sort of slightly more vicariously as well, particularly with doctors and frontline workers. So I've had during the course of my practice come across a number of frontline workers in whom I think the presentation is different, because the strongest seems to be that they feel they're not entitled to grieve, either because as a professional I should be able to manage this, everyone else is carrying on, I need to show up and continue working, or because I feel that their losses are much more significant and therefore I'm not entitled to feel like this. So I think that's one big component of how it presents in doctors, healthcare professionals, frontline workers. Within people who have had losses themselves, I think like you've already pointed out, there are a lot of difficulties in coming to terms with it because many of the rituals are lost. But also I think there are differences within the individual, within how expressive they might be. So, like with Kubler-Ross's stages, there might be denial, anger, etc. But I think what we're also seeing a lot of is numbness, withdrawing, particularly into technology. I think that's something that's perhaps new. So just sort of disappearing into mindless browsing, video game playing, whatever else, something of that sort. And I think the third thing is with people who have had pre-existing mental health conditions. I think for them, the impact has been much, much stronger, especially when people may have had previous unresolved losses. I think for them, it's very hard to make sense of a fresh loss. So there's a lot of anticipatory grief, a lot of cognitive efforts at dealing with it, or behavioral efforts, by which I mean this feeling of this just can't happen. And I think this has particularly been in the second wave, when people are frantically trying to make arrangements for ambulances, hospital beds, that sort of thing. And it's like a continuous thing. I have to make this happen. And I suppose that is connected quite a lot to the loss of control you were talking about. Suddenly everything feels so unpredictable. So I've had clients who've been unable to sleep because all day, all night, what they're doing is trying to arrange for hospital beds or ambulances or doing something of that sort. This feeling of, I cannot give up and I have to do whatever I can do. And I think this is also true of frontline workers. This feeling of, I can't stop and I have to keep going. So I think that's another big thing as well.
Fair enough. I think, Himani, you brought it out very well. And as we can see that, it has impacted people in a massive manner. And, it has changed the way how we think, what we talk, how we emote. In fact, our very sense of being, everything has, kind of got upended. That the sense of hope is being replaced by fear and apprehension. Are we able to get something? Is the relative safe? Are we safe? But the hierarchy of concerns keeps changing depending upon which wave it is, which variant it is, what is the impact, what are the political measures of the government, and the availability and utilization of vaccines. So, it's obviously so very complex. And for medical practitioners that you brought up, there are ongoing ethical dilemmas. Now, they are sitting with scarce life-saving medical resources. We are talking about ambulances. Are they available or not? Beds, they're available or not. So there's a rationing going on whilst there should not be any rationing. And along with the rationing, there is also, supply of medications. There's a rationing there as well. And, and there's a constant conflict in a medical practitioner between helping sick patients versus wanting to stay safe and protect their own family. In fact, I'm aware that quite a few doctors who have been working in the ICU in India, they decided, okay, given that they are getting into the ICU and they're working in the ICU, they would rather stay outside home so that they keep their family safe. And they haven't seen their family members for almost a few weeks. So that talks about the ethical dilemmas, about, they need to do something, and it is their role to take care of the society and the people. And then this guilt of self-care, there's a sense that, we can't be seen to be weak. We can't be seen to have emotions. We just need to keep going. And that is the complexity of the COVID-19 and grief. Now, if people are interested in data, we can talk about that. But I think it would be suffice to say there are a lot of studies there, and we do understand that there is increased levels of depression, anxiety, and stress compared to previous years. Suicidal ideation has increased, and substance use has increased significantly as well. When we talk about grief, we're really talking about an emotional roller coaster. Now, when I use these terms, I'm trying to put into perspective is that, to pick up the red flags are as to what we are trying to identify in ourselves, or what are we trying to identify in our patient population. This is what we are really trying to look at. And we understand that grief can be of various forms. Basically, we're really talking about an acute grief and an integrated grief or abiding grief. Now, what was brought up by Professor Chaturvedi was very interesting. And this is what we are going to see in the next few slides, is that now acute grief, we understand, it occurs in the early aftermath of death, intensely painful. It affects, your functioning. There are unfamiliar emotions. There's sadness and crying, preoccupation with thoughts and memories of the deceased, and difficulty concentrating. And this is the acute form of grief. But then again, if there's anticipatory grief, acute grief would be worsening of some of those symptoms there. Abiding grief is when in the next few months, when the reality and meaning of death is assimilated and people are able to start engaging in pleasurable and satisfying relationships and activities, they do not forget the people they have lost, right? Not stop missing loved ones. Loss becomes integrated into their autobiographical memory. And that's abiding grief. Now, there are factors that affect the abiding grief. And we also know that there would be periods like anniversaries, birthdays, and things like that when acute grief will reawaken. And they are the anniversary reactions that we will see associated with the COVID-19. What we need to put into perspective is that whilst grief is not only about separation from the person who died, but also is about finding new and meaningful ways of continuing the relationship with the deceased. So you lose the person, but you don't lose the relationship. And that's the key point which I'm trying to put into perspective. A question that people ask is, how long does grief last? So how long is a piece of string? The intensity and duration can be highly variable. In the same individual, right, if there are losses after losses, right, or in different people with similar losses, it can keep on lasting. And there can be various factors that can affect grief. Without going into any specific details, it's always a cumulative effect that also counts. Now, here I'm going to have a pit stop where I'll involve Himani and Professor Chaturvedi as well to ask this question of ourselves: is grief a disease? And when does grief become a disease? Why do we need to know a normal from abnormal? Why does one person develop complicated grief while another suffers from major depression or PTSD, and the other person is able to manage grief through the period of time? So let me, very quickly get Himani on board to comment for a couple of minutes about what do you think, Himani? Is grief a disease?
Absolutely not. And I think the classificatory systems are also very clear on, allowing a wide leeway on when we would consider grief problematic. But grief is certainly a very normal part of life, of experience, and must be experienced as such. So I think a number of people have pointed out that grief is also something that's quite situated in a context in terms of how the individual, how the culture, the society, the family, how, all of these perspectives matter in what is considered normal or not normal grief. I think as a, across the human race, there is a difficulty talking about grief. And in India, there certainly is a difficulty. In fact, it's not mentioned at all. And so the expectation is, once the funeral is over, once the rituals are over, you're supposed to move on. And so if you talk about it, it's sort of this, why are you talking about that person? That person's not here anymore. And something of that sort. And it makes people extremely uncomfortable. And so perhaps there is a need to sweep it away, to, brush it aside, that sort of thing, which adds to, or can actually turn grief from a normal process to something that's more complicated, something that lasts for many years, something that makes it hard to integrate loss and to accept that losses are likely to happen and that there will be more than one loss. So people who've had difficulty processing grieving for one loss can actually have a lot of difficulty with losses in the future as well.
That's right. So Professor Chaturvedi, just to get you on board, as Himani mentioned, that grief is a natural process and a part of a being's trajectory in life. The question is, why do we really need to know then the normal from the abnormal? What are we trying to do here? If it is so normal, why it is important to identify it?
Yeah, because there is normal grief, as Himani mentioned, and there is also abnormal grief. So normal grief obviously does not require any diagnosis or any intervention. And normal grief, it's very difficult to say when a person loses someone to put a time frame that it will last for 6 months to a year. My feeling is that if you had someone whom you have loved, this life you will never, never come a time when you will overcome that feeling of loss of them. So duration wise, many people consider 6 months, many consider a year as a normal grief. So it's abnormal if it lasts longer than a year. It is abnormal if it is very severe. It is abnormal if it is, interfering with one's, day-to-day function. I still like Dr. Gurmeet Singh's classification of grief, which he had given in the Indian Journal of Psychiatry, I think 1980 or 81 or something. It is very nice. It is a normal grief, abnormal grief, pathological grief, and complicated grief. So normal grief is what, Ashu, you discussed about Kubler-Ross's stages. And abnormal grief is what I was mentioning when there are abnormal presentations. Pathological grief is when either if it is inhibited grief or it is explosive grief, or they cannot get rid of the articles of the person, or if which is called as like mummification, or they cannot look at the person, or they cannot talk about the person. So these are all pathological phenomena. Complicated grief is again something which, Ashu, you mentioned. If a grief reaction manifests in the form of a psychiatric disorder because of the grieving, then it is called complicated grief. So if there is a reactive depression because of the death, or if there is a reactive psychosis because of the death, or if there is alcoholism because of the death, or if there is anxiety disorder, panic disorder because of the person's, or bereavement, then it is called complicated grief. So it is the complicated grief which requires intervention. It is the abnormal grief which requires grief therapy, and it's also the pathological grief which requires specialized grieving, interventions to help the person overcome that. So the grief reaction is not even considered. It's not considered, as Himani said, not in any of the diagnostic criteria. But if it is abnormal or pathological, it is probably considered as an adjustment disorder. And this adjustment disorder can be with the feelings of emotion, conduct, or both. And complicated grief obviously has other psychiatric diagnosis along with that. So if it was, all of us who are there, we would have, faced grief reactions because we would have lost someone or the other, either a relative or a parent or, a friend or someone. So it would be futile to call every grieving as a disorder. So every grieving is not a disorder. It's a natural reaction to death, and it is not always suffering, and it is many times, as you I think alluded to about the meaning of death. It also helps a person to evolve and grow and learn from a death of a person and move on. It's not, I mean, move on might sound a little superficial sort of a thing, but the thing is that life has to go on, and actually life goes on.
That's right. And I think that's the point, is that, it was a very good distinction that you have provided, and we'll see through the slides that, that how important is the distinction, because I think we need to put into perspective is that when we talk about loss of a loved one, it is not just the loss of a loved one. That is not the only stressor. The loved one is providing us with a sense of purpose. We do things to make them feel proud. They bring us happiness. We keep them close. We help them. We feel safe with them. And suddenly, when that loved one goes, we lose so many things. We lose our emotions. We lose the solace that they give us. We lose the derivation of self-esteem that they give us. We lose the confidence that they have provided to us, and the balance and completeness. And this is very important slide, which I wanted to show in terms of how does it really become a complicated grief, and where are those distinctions? So an acute grief with the social support, with the rituals, with the effective coping and the effective emotional regulation becomes an abiding grief. So it becomes a part of an autobiographical memory that we have lost somebody. Now, when in the COVID-19 times, the socio-environmental problems are there, the very fact that we are doing is that we're restricting rituals, we are doing social distancing. We are not able to touch somebody with our, and provide them solace. We are wearing masks, we are wearing gloves. These are the social environmental problems where the acute grief converts into much more of a complicated grief. And that's where this is a failure of transition from acute to integrated grief, which makes it very complicated. And as a result, we find ourselves in a repetitive loop of intense yearning and longing that becomes the major focus of our lives. So that's the complication related to the grief. There are a lot of risk factors related to complicated grief, including, looking into the history and previous history of mental illness and things like that. But the key bit which is important to put into perspective, while acute grief may not have complications, to that extent, there are certainly complications of complicated grief that have been kind of discovered. Increased risk for cancer, increased risk for cardiac disease, increased risk for hypertension, for substance abuse, high rates of suicidal ideation, and also suicidal behavior. Now, all of these are complications of complicated grief, and that is also another reason why we need to be able to distinguish between the normal grief and complicated grief and other various forms of grief. Now, I've just brought in an extract from an article published in the New York Times, and I think they describe it very well, that initially you feel a shock in which you feel intensely numb or intensely sad. And there is a lot of emotions there in terms of anger, guilt, anxiety, and things like that. During these early weeks, people have increased heart rates, higher blood pressure, and more likely to have heart attacks. And we have heard this many times. One spouse dies, the other person dies within a couple of weeks. Over the lifetimes, according to studies done on bereaved spouses, they may have a higher risk of cardiovascular diseases, infections, cancer, and chronic diseases like diabetes. And within the first 3 months, research on bereaved parents and spouses shows that they are nearly 2 times more likely to die than those not bereaved. And after a year, they are 10% more likely to die. Pretty high rates there. So how do we recognize the at-risk population? That is the key, is any person who is recovering from COVID, family member with COVID, somebody who's had a recent bereavement, history of mental health issues, and frontline workers. they are the at-risk population. So what are the red flags that we are seeing? Apart from all the red flags that we have talked about, psychologically traumatized patients can also present with vague somatic presentations. So if somebody starts going to their primary physician talking about somatic presentations, we should start exploring to see what is it related to and get into the history of bereavement and things like that. Social cultural contexts do shape the idioms of distress, and manifestations of grief can be quite unique in expression and context. We understand that. Now we are almost on the last legs of the presentation, and we'll talk very briefly about managing grief, but I must say that we need to manage this loss, and the meaning and significance of loss is and can be quite individualistic. Loss of a loved one to the perceived loss of autonomy and dignity. Loss is not a problem to solve. We are unable to bring the person back who has gone. And that is the key bit, that we need to be able to adapt to the loss. And that adaptation involves a dynamic oscillation in attention, alternating between loss and restoration, focused at times on grief and other times on emerging challenges. Now that's very interesting. I very recently lost one of my maternal aunts. And when I was speaking to my maternal uncle, he said, while I find myself thinking about her so many times, but then the challenges are that we need to sort the affairs as well. And it came without any preparation. And I'm busy doing that. And when I'm doing that, that is what I'm really looking at. So the point is that adaptation to loss does not mean full recovery or resolution in the sense of some complete once and for all getting over it. You don't just get over it. And it is recovery which is seen in terms of adaptation over time rather than a final outcome. Now, let's talk about adaptive coping. There are various techniques of adaptive coping, including accepting, focusing on what is one grateful for, reaching out, maintaining some sense of self by routine and things like that. It's important that we put in perspective that in some consultations, there is little that we can do beyond witnessing, hearing, and acknowledging a patient's pain, trauma, and grief. We find that our hands are tied. That's the best that we can do, that we can just hear and acknowledge. And we have found that studies that resilience can be fostered by focusing efforts to master the possible, accepting that which is beyond control, and coming to terms with what cannot be changed, which is almost akin to the serenity prayer that we might have heard in our lives. God, grant me the serenity to accept the things I cannot change, acceptance, courage to change the things I can, and wisdom to know the difference. And that is the key bit, irrespective of any religious beliefs, that this is a prayer that quite a few people use sometimes to be able to accept what is going on and to be able to move on. It's ultimately reconstruction of meaning. And our role as clinicians is not to provide meaning for those who are struggling, but to facilitate their meaning-making process. Viktor Frankl, 2006, it's very important that we put in perspective. We have to facilitate their meaning-making process, and they need to find a meaning of that particular loss and how it evolves in terms of finding expressions in continuing patterns of interaction. And how do they integrate that loss with other life experiences? Now, when we talk about hope, we should not be seeing hope as relentless optimism and good cheer. We need to be able to distinguish between reasonable hope and what are false hopes. A wishful thinking does not make a pandemic go away. So we need to be careful in terms of what are the practical things that we need to put into place. So as we talked about, that grief is a healing process. We have to, over a prime, we have to heal. We do not get over grief. We just go through it over a period of time. And that is the key back. It's not about, you'll be fine, just bounce back. No, you will not be fine. We just need to be able to manage. So I find this as a very good way of managing grief, but as long as it is just a normal grief. Do nothing that will inhibit the expression of appropriate grief. So allow appropriate grief to be expressed. The bereaved person has a painful and difficult task to perform that cannot be avoided or rushed. We cannot avoid or rush it. A true help as a friend or as a family member would be to recognize this fact and help the bereaved to arrange things in whatever way it's necessary to set him or her free for the task of grieving. But being very careful that we are not on the verge of pathological or complicated grief. I found this cartoon very interesting. So what to do with this grief? Well, you get the special grief adapter and place it over your heart, and you plug the cable into the cycle. It helps the wheels to go around, and let your grief carry you, let it help you. So flow with the time and grieve. And the same is with joy. Plug it in and let it carry you. Don't inhibit the expression of grief. Now, let us see if I can play this video. It's only for a few seconds. And I think what I would do is, after playing the video, I'll get Professor Chaturvedi and Himani to comment over what do they think. It might take a couple of seconds for me to link it, but let me see how I go with that. I'm sorry, I think the video was not audible, but I think I'll send you the link of that. It is a very interesting video which talks about that when you talk about pain and you talk about grief, you're really focusing on not just the pain and grief and not inhibiting it, but accepting it and helping the person grieve over that. And that is the key message that I wanted to put across. Now, let's go on to the next couple of slides. Are you able to see the slides now? I hope, yes, you are. Right. So basically, to summarize, and that's the key bit that we need to put into perspective, is that we need to facilitate the expression of grief. We need to reveal feelings that block natural grieving and make sense of these feelings, address the social isolation, and provide a secure base. So before we go on to the last couple of slides, maybe if I can get Professor Chaturvedi to comment about management of grief in a busy outdoors clinical setting.
Well, like we discussed, all griefs don't have to be managed. It is only a small proportion of grief reactions which are either abnormal or which are complicated or which are causing a lot of distress and suffering, which need to be provided some help. There was one comment which you had made earlier about how to make a diagnosis of this, and in any psychiatric outpatient, such phenomena are likely to be misdiagnosed as major depressive disorder or some other psychiatric disorder, unless the the resident or the student or the psychiatrist or the psychologist asks about any death which has happened and links it with that, and finds that the pain of missing the person, the pining for the person, and the thoughts of that person are actually predominating the picture, and only then one would like to provide a management for grief. And obviously, I mean, it's one could either do individual grief therapies, because every death is special for the person, and every grief is very unique for the person, and they would need to be given psychological or psychosocial help to provide with that. After a while, I think, when in situations like this, like in the pandemic, the question which you're asking, there are not enough grief counselors, and there are not enough either even mental health professionals to provide help, is to consider whether one could have one could think of group therapies for grieving for the caregivers who have been bereaved. And because some of the circumstances are similar, if they are, for example, with the COVID, so the experiences are similar, so you can have group therapies. But now, in the last year and a half, since in-person therapies have been literally impossible, it is to provide these in an online method. And even I know of groups who are doing online group interventions for grief and grief counseling, and it is as simple as from a helpline, but that is not really intervention, but it actually provides where they could get intervention, and then for also some sort of a psychological support, psychosocial support, which would be required. One thing which we should remember is that it does not require medication, and that is the thing which happens if they land up in very busy psychiatric clinics with a psychiatrist, and they would try to manage it symptomatically by giving antidepressants or anti-anxiety agents, and that is not going to help in overcoming the grief. But I'm quite sure Himani might be able to give better understanding of how it would be possible to provide counseling and therapy for grief for a large number of people.
That's right. And Himani, I was just wondering, so virtual contact with the person to provide counseling as opposed to face-to-face, and what are the challenges of this work during the COVID-19 times?
I think when we first started telepsychotherapy, we found that there were so many challenges that we had not anticipated. I think that as therapists, we expect that the work we're doing face-to-face, we will seamlessly shift it onto the screen, and that rarely happens. There are so many things, internet disconnections, interruptions, the difficulty of not seeing the person face-to-face, and not knowing, as clinicians, I think we ourselves are uncomfortable with not having the person in the same room. For clients as well, I came across a really interesting article on the neurobiology of emotion regulation, and how for humans, simply having another person in the same room is itself enough to regulate emotion. That itself, causes changes in the brain and the sympathetic, parasympathetic nervous system, so that we manage to regulate emotion. Just having another person in the same room, that's enough for us. So obviously then translating it to a screen, the challenges are so huge. The other thing Professor Chaturvedi said about not having enough mental health professionals, not having enough people to deal with it, I'm going to add the fact that grief is not talked about, that there is no permission as a culture, perhaps, even as a human race, to actually grieve. I think that contributes hugely to it, because most of the people that I work with, there's a lot of shame, a lot of guilt, feeling like, they're taking up time by talking about this as a sort of embarrassment. And I think for people who are listening as well, the feeling is, now I don't know how to respond. And, like you were saying, this is not reversible. There's nothing the other person can do to fix it. And the helplessness itself also contributes to people sort of saying, yeah, well, and, trying to use distraction, or changing the subject, or doing something else. So I think that's a big challenge as well. I mean, not specifically with teletherapy, but I'm saying in general around grief. But also I think, perhaps I'm just going to sort of add to that by saying that I think there are a number of things that can be done, which perhaps don't have to be done at the level of treatment. But the sense that, as we're talking about grief in different stages, in the early stage, the need is simply to tell and retell the story. What happened, why it happened, how it happened, and examining it, dissecting it. And perhaps also thinking about what I could have done differently. Could I have prevented it in some way? And this is perhaps common for doctors as well. If talking about deaths, patients in the ICU, or things like that, there can be a lot of self-blame, a lot of guilt, etc. around that. But and this is in the initial weeks following the loss, but the later phases, in the months following the loss, the real need is to try and understand how to keep the person alive. And this is where the trying to talk about what that person meant to me, the stories, trying to come up with some sort of memorial, what was important to the person, that comes in. But we can see that in all of these stages, what you put up in that cute little video, Dr. Ashu, about what's important is just witnessing it. And that's all the other person can do. Just sit with them, listen to them, however many times they want to talk about it. And later on, in the years following, the need is about how have I changed as a result of this loss, or how do I see myself? And this is where a lot of change in self, change in the society, like altruistic endeavors, wanting to bring about some change in the society to perhaps make sure this doesn't happen as much, or things like that may come up later. But in the initial phases, we don't really need treatment. We don't perhaps need a professional, but it's enough for another person to listen to the person talking about whatever they need to at that stage, and perhaps being numb as well, and not feeling like I don't know what it means to me and I have nothing to say, but still once in a while, whenever they want to talk about it, and being okay with the roller coaster as well.
That's perfectly said, Himani. Just being there, and I think that's the key bit. Not thinking that we need to be specially qualified to be able to help. Being there is help enough. And I think it's very important to put into perspective that when we talk about caring for the bereaved, we need to put into perspective that when death ends the life, it does not actually end relationships. Time does not heal all wounds, but time offers new perspectives, experiences, and connections that can help people forge new meaning and purpose in their lives. So when Professor Chaturvedi said move on, and that's the moving on, which is not in terms of moving on from the person you have lost, but moving on in terms of integrating new perspectives, experiences, and connections. Over time, we will need to integrate the pandemic experience into the chapters of our individual and shared lives, strengthening the relational connections that matter to us, with the families we were born into, those we choose, and our wider communities. So time actually does not heal the wound, but it just offers new perspectives, experience, and connections. The weight that we carry reduces, and it is integrated into our autobiographical memory. Russ Harris, who's written The Happiness Trap, based on the ACT, he has mentioned some principles around face COVID. But the most important things that I pick out of this are the first two. Focus on what's in your control, try to manage that, and acknowledge your thoughts and feelings. You all can more than welcome to Google Face COVID and read through. And, we don't really have time at this point in time, but just the last couple of slides. Loss of a loved person is one of the most intensely painful experience any human being can suffer. And not only it's painful to experience, to the bereaved, nothing but the return of the lost person can bring true comfort. Should what we provide fall short of that, it is almost felt as an insult. And as Macbeth says in Act 4, Scene 3, line 208, never pull your hat upon your brows, give sorrow words. The grief that does not speak whispers the overfraught heart and bids it break. So give sorrow words, and I'll end this presentation with giving sorrow words. And I'm more than happy, along with my panel members, esteemed panel members, to answer any questions. But I have been seeing on the panel, question and answer panel, it doesn't seem to be that there are any questions. But I must thank all the panel members, Professor Chaturvedi as well as Himani, for interacting so well. And Deepti, I'll hand it over back to you to close the session.
Thank you so much, Ashu, Santosh, and Himani, for that very insightful and gentle discussion that you've had with us today. I really hope that it helps medical practitioners deal with their patients in a better way. Now, we do understand that parts of the talk might have been distressing to our viewers. So here are some support services in your local area if you do require assistance or support. Please don't hesitate to email us if we can help in any way. With that, I'd just like to thank all our panelists and speakers. Thank you very much. We really appreciate your contribution.